For decades, the medical community accepted a specific trajectory for the aging heart. The left ventricle stiffens, coronary plaque accumulates, and the patient progresses toward heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction, or HFpEF, is a clinical condition where the heart muscle becomes too rigid to fill properly between beats. However, clinical data suggests that what we categorize as age-related decline is frequently the result of physical deconditioning. Decades of reduced mechanical loading, the simple absence of movement, drive these structural changes. The biological state of the heart and vasculature is dictated by cumulative physiological stressors and lifestyle interventions, rather than the movement of a chronological clock. When viewed as a consequence of disuse, cardiovascular decline becomes a correctable condition, establishing targeted physiological reversal as a viable clinical goal. To isolate the effects of unloading from actual biological aging, researchers utilize extreme models of inactivity, such as spaceflight and prolonged total bed rest. This research was pioneered by Dr. Benjamin Levine at UT Southwestern. UT Southwestern is a leading academic medical center and research institution located in Dallas, Texas. Levine's landmark Dallas Bed Rest and Training Study observed healthy 20-year-old men subjected to 20 days of total bed rest. This brief period of unloading caused a reduction in cardiovascular capacity more severe than 30 years of natural aging in those same individuals. The histological data from this study confirmed that unloading causes the heart muscle to shrink and the left ventricle to become significantly stiffer. The heart stiffens primarily because it lacks mechanical stretch. This proves that age-related changes can be induced in weeks and suggests they can be physically reversed through the application of specific mechanical loads. In the sedentary body, the central arteries undergo a specific structural change. Fibrosis develops, and collagen fibers cross-link within the arterial wall, binding rigidly together and destroying the elasticity of the vascular system. As the central arteries lose their ability to buffer the heart's energy, systemic arterial stiffness increases, driving up effective arterial elastance. Effective arterial elastance, or EA, is a measure of the total afterload the heart must overcome to pump blood into the body. Chronic exposure to this high afterload is the primary precursor to clinically untreatable HFpEF. Because this condition is difficult to manage once established, identifying a window for structural remodeling is a clinical priority. This graph illustrates the model flow aortic age algorithm, a tool developed by Levine's laboratory to quantify intrinsic structural stiffness. Model flow provides a reproducible metric of vascular age, unlike standard pulse wave velocity. Pulse wave velocity, or PWV, is a common stiffness measure that is often confounded by transient changes in a patient's blood pressure. The algorithm calculates intrinsic aortic compliance by mapping the central aortic pressure waveform against the subject's stroke volume. A compliant aorta buffers the pressure, while a stiff aorta produces a sharp, high-amplitude pressure spike. The clinical data shows that while sedentary seniors have aortic ages matching their chronological age, competitive masters athletes, those who have trained vigorously for over 25 years, possess aortas biologically 25 to 30 years younger than their chronological age. Biological vascular age is mathematically distinct from chronological age. It is a malleable physical state that can be targeted through specific training protocols. There is a clear temporal limit to this plasticity. Past age 65, the structural stiffening associated with a sedentary lifestyle becomes largely irreversible through standard exercise interventions. This creates a critical sweet spot in late middle age, between ages 45 and 64, where the heart remains plastic enough to be physically remodeled. This timeline matrix details the Prescription for Life protocol, which centers on the Norwegian 4x4 interval session. High-intensity interval training, or HIIT, involves short bursts of near maximum effort followed by low-intensity recovery. The protocol requires 4 minutes of activity at 90 to 95% of maximal heart rate, followed by 3 minutes of active recovery, repeated 4 times. This intensity is required for a specific mechanical reason. Only near maximal cardiac output provides the repeated stretching of the myocardium necessary to restore the physical compliance of the left ventricle. Casual physical activity cannot induce these changes. Only a structured, high-intensity mechanical dose can forcibly remodel the heart's internal structure. This anatomical map illustrates that the cardiovascular system is not monolithic. The dose of exercise required to prevent stiffening depends on the size and location of the blood vessel. Preserving the large central arteries, like the aorta, requires a committed dose of 4 to 5 sessions per week over a lifetime. Middle-sized vessels, like the carotid arteries, are more responsive. A casual dose of just 2 to 3 sessions per week is sufficient to minimize stiffening here. However, small peripheral vessels in the limbs show almost no structural change regardless of the exercise dose. The primary anti-aging benefits of exercise are localized to the central vessels that buffer cardiac output. Protecting this core system requires a high-frequency, lifelong commitment. High-intensity training modifies the cellular environment within the coronary arteries. The high-velocity blood flow creates shear stress against the endothelial wall. Clinical trials like SENET and the Lifestyle Heart Trial, which used advanced imaging, demonstrate that this stress triggers the regression of actual plaque volume. This shear stress upregulates endothelial nitric oxide synthase, or eNOS. eNOS is an enzyme that produces nitric oxide, a molecule that promotes vasodilation and prevents the inflammatory response of the vessel wall. Vigorous exercise also generates lactate, which acts as a signaling molecule. As shown here, lactate binds to the GPR81 receptor, triggering a cascade that increases the expression of the Kruppel-like factor II transcription factor. Kruppel-like factor II, or KLF2, is a protein that inhibits inflammation within the artery. Furthermore, exercise promotes the lactylation of proteins in macrophages. This process shifts these immune cells from an inflammatory state into an M2 anti-inflammatory state, where they actively aid in plaque stabilization. These molecular pathways explain the athlete's heart paradox. Older endurance athletes often possess higher coronary artery calcium scores than sedentary people. A coronary artery calcium, or CAC score, is a CT scan measurement of calcified plaque in the heart's arteries. Under the molecular conditions created by exercise, this high calcium is a beneficial adaptation. The body uses calcium to stabilize vulnerable plaques by thickening their protective fibrous caps, preventing rupture. In high-intensity athletes, elevated coronary calcium is not a marker of risk, but a sign of active exercise-induced plaque stabilization. This line graph, plotting mortality risk reduction against minutes of exercise, demonstrates that cardiovascular durability has clear physiological limits. Moderate physical activity, or MPA, includes low exertion tasks like walking and shows a linear benefit with no known upper limit. However, the curve for vigorous activity reaches a distinct plateau. The maximum reduction in cardiovascular mortality is reached at approximately 150 minutes of vigorous activity per week. Beyond this point, the data forms a slight reverse J-curve, suggesting a plateau in benefits. Extreme long-term training volumes can lead to atrial stretching and increased vagal tone. This increases a risk of paroxysmal atrial fibrillation by 16% for every decade of heavy exercise. Atrial fibrillation, or AF, is an irregular and often rapid heart rhythm that can cause blood clots and stroke. Strength training follows a similar narrow curve. Survival benefits are maximized at 40 to 60 minutes per week and begin to degrade once training exceeds 130 minutes per week. Cardioprotection is governed by a specific dose-response relationship. Precision in training volume is required to maintain the heart's structural integrity over time. Advanced ECG metrics identify a significant gap in our current diagnostics. Advanced ECG, or AECG, uses deep learning to identify subclinical heart disease from standard electrical signals. Many patients possess a heart age gap, where their cardiovascular system is biologically 7 to 14 years older than their chronological age. Providing patients with a biological baseline, rather than an abstract risk percentage, significantly increases patient adherence to medical protocols. Dr. Levine treats the 4-5-day-per-week exercise prescription as a standard requirement of daily hygiene. Through the activation of the eNOS pathway, the upregulation of KLF2, and the application of targeted mechanical stretch, the middle-aged heart can be structurally rebuilt. Cardiovascular aging is a malleable physiological state. By intervening in the middle-age sweet spot with a precise mechanical dose, we can halt and reverse the biological decline of the human heart.